My name is Suraj Singh, and I'm a radiation oncologist that specializes in prostate cancer at Parkview Medical Center in Colorado. The timing of this webinar is especially appropriate because September is Prostate Cancer Awareness Month, and this webinar is one of many educational events that Barrigel will be holding in honor of prostate cancer patients. Today, we'll be discussing evolving and expanding roles of radiation therapy in metastatic prostate cancer patients. More specifically, we're going to talk about the recent update of the PEACE-1 trial at ASCO 2023, which really sought to clarify the role of radiation therapy to the prostate in metastatic castrate-sensitive prostate cancer patients. So the treatment landscape of metastatic castrate-sensitive prostate cancer patients has evolved considerably over the last decade. Prior to 2015, these patients were treated with ADT alone. And in 2015, after the publication of Stampede, these patients began to be treated with ADT in conjunction with docetaxel-based chemotherapy, which was shown to improve survival. In 2017, the standard of care changed yet again with the addition of abiraterone, which is a drug that blocks endogenous androgen synthesis, along with prednisone, after the publication of the Latitude trial. That showed that abiraterone and prednisone, in addition to ADT, improved overall survival as well as radiographic progression-free survival. The addition of abiraterone also improved all secondary endpoints, including time until pain progression, time until the next subsequent therapy for prostate cancer, time until initiation of chemotherapy, time until PSA progression, and along with time until symptomatic skeletal events. In 2018, Stampede also showed that adding radiation to the subset of patients decreased failure-free survival. And in 2019, a randomized phase 3 trial found that adding enzalutamide to testosterone suppression increased survival, as well as PSA progression-free survival, as well as clinical progression-free survival. It's essential to note that these changes in standard of care for this group of patients was ongoing during the accrual of PEACE-1 during 2013 and 2018. So moving on to the specifics of the PEACE-1 trial, eligible patients had de novo metastatic castrate-sensitive prostate cancer and could have received up to 3 months of ADT prior to randomization. Patients were stratified by performance status, metastatic site, type of testosterone-lowering therapy, and eventually the use of docetaxel. A total of 1,173 men were randomized to the 4 arms, 1-to-1 to 1-to-1. On the right side of this graph are the 4 arms of treatment. The standard treatment or standard of care treatment was continuous ADT or bilateral orchiectomy, and eventually docetaxel. The second arm was standard of care with abiraterone and prednisone until disease progression or intolerance. The third arm was standard of care with radiation, which was delivered to a total dose of 74 gray in 37 fractions to the prostate alone. And the fourth arm was standard of care therapy plus radiation plus abiraterone with prednisone. As we discussed before, after the Latitude and Stampede results were published, docetaxel administration eventually became mandatory and essentially made this 4-arm trial an 8-arm trial due to the change in the standard of care across all 4 arms. The first interim results were released in 2021, and this update clarified the role of abiraterone therapy. This graph on the right shows that the addition of abiraterone, represented by the red line, to the standard of care treatment, which is represented by the blue line, significantly improved radiographic progression-free survival from 2.2 years to 4.5 years. The investigators then reported on the impact of abiraterone on radiographic progression-free survival in the subset of patients who received both ADT and docetaxel as part of their standard of care arm. Even in this subset of patients, abiraterone improved radiographic progression-free survival significantly from 2 years to 4.5 years. This improvement was seen regardless of disease burden, with benefits seen in both the high metastatic and low volume metastatic cohorts of patients. The addition of abiraterone to the standard of care arm also significantly improved median overall survival from 4.7 years to 5.7 years. The investigators then reported survival numbers on patients who received ADT with docetaxel as part of their standard of care arm. They found that the addition of abiraterone also significantly improved median survival in this subset of patients. It was 4.4 years in the ADT and docetaxel arm, which is represented in the blue line, and was not reached when abiraterone was added, represented by the red line. So before we get into the most recent update regarding the role of radiation therapy in these patients, this is a slide that recaps how patients specifically with low volume metastatic castrate-sensitive patients are treated. We know from prior data there's no clear role for triplet therapy in this population. So the standard of care is ADT with docetaxel or ADT with abiraterone. We also know from the STAMPEDE Arm H results that adding radiation therapy to the primary for low volume disease improves failure-free survival and overall survival. We'll go more into the specifics of that data later in this talk. And in the US, most use abiraterone rather than docetaxel. So prior to these piece one results, we haven't had a clean trial of ADT with radiation with or without abiraterone, or ADT with abiraterone with or without radiation therapy. So moving on to the most recent update on the piece one trial regarding the addition of prostate radiation. We know that about half of the standard of care patients received ADT and docetaxel. So despite some of the low volume patients receiving excessive treatment with ADT, docetaxel, and abiraterone, the addition of radiation therapy to that subset of patients still significantly improved radiographic progression-free survival to a median of 7.5 years, which is represented by the black line on the graph. Conversely, adding radiation to standard of care without abiraterone was not associated with an improvement in radiographic progression-free survival benefit. In terms of overall survival, adding radiation therapy to either standard of care alone or standard of care with abiraterone did not significantly improve overall survival. There certainly were modest survival benefits associated with adding prostate radiation, but the study was underpowered to detect overall survival, with each arm being tested only having about 126 patients in it. It is, however, important to note that standard of care with abiraterone plus radiation therapy had the best overall survival, but with each arm having fewer than 130 patients, it was hard to produce statistical significance. And when you compare this with STAMPEDE Arm H, which had over 2,000 patients randomized, you can see why it was difficult to prove that the addition of radiation would improve overall survival in this trial. The addition of prostate radiation to the standard of care with or without abiraterone in the low volume cohort was associated with significant improvements in the time to severe genitourinary events. When you look at the subset of patients who received standard of care with abiraterone and radiation, there were only a total of 6 serious GU events in 126 patients. Conversely, in those that received standard of care with abiraterone without radiation, there were 20 serious GU events found. A similar benefit was seen in the overall cohort of patients as well. When you look at the subset of patients who received standard of care with abiraterone and radiation, there were only a total of 24 serious GU events in 221 patients. Conversely, in those that received standard of care with abiraterone without radiation, there were 45 serious GU events found. In terms of castration resistance-free survival, adding prostate radiation to standard of care with or without abiraterone was associated with significant improvements in both the low volume and overall cohorts of patients. Adding radiation therapy to the low volume metastatic subset of patients improved castration resistance-free survival from 2.5 years to 3.4 years. And adding radiation therapy to the overall subset of patients improved castration-free survival from 1.9 to 2.5 years. Finally, this slide shows the side effects of patients in the study, and they were remarkably similar whether they received radiation therapy or not. So what conclusions can we draw from the 2023 update? We know that adding radiation therapy with intensified systemic treatment, which is abiraterone with or without docetaxel in low volume de novo metastatic castrate-sensitive prostate cancer, improves radiographic progression-free survival. It improves castration-free survival. It does not improve overall survival, but as we discussed, the study is underpowered and there are trends towards improved overall survival. We'll briefly discuss the STAMPEDE Arm H later in the talk, which does show survival benefit with adding radiation. And the standard of trial for low volume metastatic castrate-sensitive prostate cancer is either ADT with docetaxel with prostate radiation therapy or ADT with abiraterone plus prostate radiation therapy. So I wanted to spend a couple of minutes to discuss the STAMPEDE trial. This trial is one of the largest ever clinical trials for prostate cancer, and as you can see, it had several arms in it. To be eligible for STAMPEDE, patients were newly diagnosed as metastatic, node positive, or high-risk locally advanced, or relapsing following radical prostatectomy or radical prostatectomy with high-risk features. Specifically, I want to look at Arm H. This arm randomized 2,061 patients to ADT with or without prostate radiation therapy in newly diagnosed metastatic patients. Radiation therapy was delivered either to a total dose of 55 gray in 20 fractions over 4 weeks or 36 gray in 6 fractions over 6 weeks. Initially, there was no overall survival advantage noted with radiation therapy in the overall population, but there was a statistical improvement in failure-free survival. Patients were defined as having a high metastatic burden if they had 4 or more bone metastases with 1 or more outside the vertebral bodies or pelvis, or visceral metastases, or both. Everything else was considered low metastatic burden, and when that low metastatic burden patients were analyzed, the addition of radiation therapy to the prostate improved 3-year overall survival from 73% to 81%. Radiation also significantly improved failure-free survival in this subset of patients, and a 5-year update confirmed that increased survival with the addition of radiation from 53 to 65%. It also found that the side effects of radiation therapy were manageable without any impact on long-term quality of life. So what did we learn from all of these studies of men with newly diagnosed low-volume metastatic castrate-sensitive prostate cancer? First, we know that ADT plus treatment intensification improves overall survival. Second, we know that ADT plus radiation to the prostate increases overall survival. Third, ADT plus docetaxel plus radiation increases overall survival. And fourth, ADT plus abiraterone with or without docetaxel and radiation therapy increases radiographic progression-free survival. It has the numerically best overall survival, but a tiny subset of patients, and it delays the time to serious GU events over ADT and abiraterone with or without docetaxel. So once again, the standard of care off trial for low volume metastatic castrate-sensitive prostate cancer patients is either ADT and docetaxel with radiation or ADT and abiraterone with radiation therapy. So we know that patients with low volume metastatic castrate-sensitive prostate cancer can live for a long time, and STAMPEDE showed a 5-year overall survival of 65% with the addition of radiation. I would argue that this subset of patients would benefit from rectal spacing to reduce GI toxic events. And in my practice, I use Barrigel for this subset of patients. This last slide is a summary slide of the randomized clinical trial of Barrigel for hypofractionated radiation therapy to the prostate. For this trial, patients that were eligible had biopsy-proven T1 and T2 prostate cancer, Gleason score 7 or less, and a PSA of 20 or less. They were randomized at a 2-to-1 ratio to having spacing versus no spacing, and they were stratified by intended ADT use and erectile quality. The results showed 98.5% of spaced patients had a 25% or more reduction in rectal volume receiving 54 gray, and the mean reduction was 85%. And 2.9% of spaced patients versus 13.8% of control experienced grade 2 or higher GI toxic events, which was highly significant. So the takeaway from this study is that this is the only randomized study shown in trial to include ADT and hypofractionated radiation therapy, and it's the only rectal spacer shown in trial to reduce grade 2 GI toxicity.